I've heard already that most of us are using a proteasome inhibitor, an IMiD, aiming for a deep response. MRD, it sounds like we're all using MRD testing in our clinical practice already, at least in academic centers. Is there any risk stratification going on? Do people still need to do FISH testing? If everybody's going to get VRD and transplant, is that test you still recommend, Sagar?
Yeah, so from our perspective, we think that where you really begin to tailor it, as Gareth was talking about, is in the maintenance setting. And so we find that information useful because it tailors how we're going to put people on the post-transplant consolidation and maintenance arm. And I think one of the, just to sort of build on that a little bit more, one of the important points that I think Gareth brought up is that I think the days of saying, I'm just going to put people on a regimen and see what happens, hopefully those days are over.
Yeah.
Because we really need to think about what is my 3-month, 6-month, and 12-month plan for a patient with newly diagnosed myeloma, because we got to treat them for more than just 4 cycles.
Good point, Tom.
I couldn't agree with that more. And many of our clinical trials do just take, here's the regimen, and you're going to do it for 16 cycles or 18 cycles, go. Where that's not the way we practice clinically, right? So we do need these risk-adapted clinical trials that are going to take people for 4 cycles. You do some intervention, see what's happening, and if it's not good enough, you switch to some other regimen. I think we need that more in our field.
My point would be not to argue against the point you made about stopping if you're MRD negative. It's what you do if at a year on maintenance you're still MRD positive.
Yeah.
Do you do something extra
right.
for those patients?
Let's come back to the maintenance question in a minute. I just want to focus a little bit more on this risk stratification question. And just talk me through, Ivan, a young patient who's got a P53 deletion at diagnosis. Do you treat them any differently than somebody who's got low-risk genetics?
We actually do. And I would say that, I think this is by FISH, I'm assuming that you're talking about. We've been using also MyPRS that came out of Arkansas. And I think the interesting thing about
MyPRS, the audience, is a
the myeloma
based
right,
test. Right,
exactly. And I think there's a lot of very nice data to suggest that FISH and the molecular signature may not necessarily correspond, but assuming that they do, our approach off protocol has been, off of a specific protocol, has been to talk about sending these patients to an allo transplant following induction therapy. Okay. And we're able to do that now. I know there's a lot of controversy, and we'll probably talk about it, but our transplant-related mortality now with allo is in the order of around 5%. Right. And, and with an incidence of graft versus host disease, grade 3, grade 4, in the 10 to 15% range. And so we are seeing patients that achieve a CR have remissions that are out to up about 5 years median.
Anybody else doing allo transplant in high-risk patients?
So I would say that the high-risk patient setting is probably more the setting that we're going to come to at the end of the discussion when we start talking about CAR Ts, because it's a natural place to put those agents.
Okay, very good.
I would be curious with you, Gareth, answering, if somebody has 17p deletion by FISH, that's truly a variable disease process, correct?
So we have a paper that's just come out in Hematologica that shows that there is a cut point, and you have to, in lower risk patients, use a 60% cut point. But we've also got some data that it's biallelic inactivation of P53 that's crucial, where you lose one copy and mutate the other.
We're getting a little bit into the weeds here, so I want to keep it at a higher level for a second. We're talking a lot about younger patients, but we have to realize in the community there's a lot of older patients out there. Tom, an older patient with high-risk disease, do you treat them any differently than a low-risk patient who's more elderly?
We do, and pretty much we follow the RVD light protocol. So we give the same agents. We just give them in lower doses. We see how they tolerate them at lower doses, and we can increase the dose if it's tolerated well and they're not having such a good response. We'll just kind of do a risk-adapted design for each individual patient. We also, in that patient population, if they're not doing well on bortezomib, lenalidomide, we would switch them to carfilzomib or to pomalidomide. We would give them something more intense if they could tolerate it.
You've kind of pursued that approach in your MRC trials, Gareth, where you've failed to have a good response, you switch therapy. And
so I think that's the first trial that in myeloma, at least, there's been an adaptive design from the beginning, and it shows that people aren't primarily
just
resistant.
For our audience, tell us what you did in that study so we understand.
They were exposed to an IMiD initially. If they didn't respond
well, IMiD being lenalidomide probably, or thalidomide.
Yeah. If they didn't respond well to that, they were allowed to swap, and we randomized to exposure to a proteasome inhibitor combo or nothing. and people who had stopped responding responded to the proteasome inhibitor combination, had better responses, better PFS, better OS.
But you don't know that you can extrapolate that to somebody who's getting an IMiD PI up front together.
So I interpret it as being a biological message about resistance, but that the optimum induction would be a proteasome inhibitor, an IMiD drug, probably an alkylating agent and DEX. And so we have the follow-on study was KCRC.
All right. Since you mentioned alkylating